everybody. Welcome to Being Kambua. My name is Kambua, and I am so happy that you have tuned in. And this is that place where we get to listen to one another's stories, we get to trade stories, we get to encourage one another, and we also bring in specialists into the mix because hatutaki kudanganyana and to share misinformation. We have to get the right information and share the right information. And I'm really glad and grateful that on season 4, particularly, we've had several professionals with different specialities come in to just talk to us about our bodies, how they function. You've sent in your questions, what could be the problem, and they've been answering those questions. And this is because you guys told me, Kambua, bring someone who can talk to us about conception, who can talk to us about our periods and all of these. So I listen, keep sending your feedback, and I'm so happy to do the best that I can to just make this community more meaningful for you. I'm so grateful to Dusit Princess for this space. It's beautiful. They've hosted us so graciously. And bring your friends over if you want to have some lunch or dinner or have a meeting here in the executive lounge. It really is a beautiful hotel. Now, let me dive right into this. When I started seeing all of you sending in different questions that were in relation to fertility, infertility, and I said, okay, number one, I cannot answer these questions because maybe myself, I don't know, but I know somebody who can. So as we were digging, we were like, why don't we bring Dr. Thuo? Because tumemwona on social media and other places, and and I know people who are close to me who worked with Dr. Thuo, and I knew that we can actually glean from this well of wisdom, and I don't take it for granted that he said, yes, Kambua, I will come, I will sit with you, and we'll have this conversation. Karibu sana daktari.
Thank you very, very much.
It's so good to have you here.
Glad to meet you as well.
He has had a full day, as you can even see. This is evidence. So
Absolutely.
I don't take this time for granted. Thank you so much. Dr. Thuo, I was trying to get your title or your specialty right before we got on. So you're a obstetric gynecologist?
Obstetrician gynecologist.
Yes.
And fertility
specialist.
Yes.
Don't ask me to repeat that. Beautiful people, I hope you caught it. I'm very curious to know, and this is always my first question when somebody tells me this is what they do, this is my specialty. Why did you choose that path?
Wow, very interesting. So, in our family,
yes,
no one is in the medical field. Absolutely no one.
Okay.
So went into, you do your primary school and then your secondary school and then your results come out. So I actually originally went into flight school.
Oh,
yeah. So went into flight school,
yeah,
started out doing, of course, the aviation,
yes,
and your private pilot's license and all that. Then came in the invite. Of course, now I've been invited to the University of Nairobi,
yes,
and to take up this course. During our years, you'd have to wait for a period of about 2 years, I think, after you've done, after your results are out.
Mm-hmm.
And being called, of course, for medicine,
yes,
then you had to go there. And we would say, back in the day, that there were two people who were quite disadvantaged, I think, with the school system. If you were doing well and you're not doing very well, because sometimes when you get, let's say, for example, when you're doing the whole, depending on how your grades go,
yeah,
you are boxed in and you have to do this particular course.
Yes.
So not having had a background in medicine or mentors in medicine, then you're pushed into this field where you had to now sort of get a feel about it.
Yes.
And going into internship, then it started, of course, you had a gravitation towards, maternal health and reproductive health, and
yes,
dealing with the, from conception to gynecological issues all through delivery. So yes, so the passion grew in through school and then transitioned into practice. Yes.
Wow, that's amazing. I think that's so fascinating because everybody's journey is so different. There are people who are like, since I was born, I always knew I wanted to be a doctor. And then there's you who wanted to be a pilot, and the path led you differently. And here you are helping mothers bring life and helping families. Is your work exciting?
Absolutely. Yeah. Never a dull day.
Yeah.
Never a dull day. Yes, it is. Very exciting.
Is your work, because you're so, you're doing work that involves a balance, such an intricate balance between life and death for mothers and babies. How do you, as a doctor, manage to continue your practice, take care of these women, take care of the children, take care of these couples, and also take care of yourself, not to get lost in all of that? Because I imagine it's a lot.
Yes, it is a lot. I'm fortunate to have my even business partner and life partner,
Yes.
Dr. Martha, who we work together with, and of course then keeps me in check.
Yes.
So we have our, designated family time,
Okay.
and then also being in the profession, exact same profession, is able to understand how the other side works in terms of your midnight calls and your having to leave in the middle of the night. So
Yes,
that is
yes.
understood, and of course not everybody in this profession is as fortunate, and so it really helps.
Yeah.
And you do not have a choice sometimes.
Yes.
So it is, this time we're taking a holiday.
Yeah.
Now we need to do this.
Right.
You have to be here for this particular function. So
Yeah.
that keeps somebody grounded.
Yes,
and
for
humble.
sure.
Yes,
Yes.
absolutely.
Now, I told my people to send me questions, and they did. So I want us to dive right into it and just,
absolutely.
respond to some of these questions. And the very first question I want to give to you is, why unexplained infertility? Why is there no reason for infertility? I just want one reason.
Idiopathic. So we use the word idiopathic, which sometimes is translated that that the doctors have no clue.
Yeah.
Because all the information, let's say the tests that we can do,
Yes.
that would be possible causes for lack of, that a couple would not be able to conceive, cannot be found. So everything is very okay. So we basically do 4 main tests. Is how are your fallopian tubes, are they open?
Yes.
What's the quality of your egg? What's the quality of your sperm? And then how is the anatomy of the uterus in terms of ultrasound and etc. So if we do all those 4 tests, and everything is quite okay, you are regularly active, then after a period of 6 months to a year, depending on how your age is, then we then say that it is unexplained
infertility. It's one of the most frustrating things, and I can hear the frustration in her question, because you want to at least know it's this thing. Then can we deal with it or can we not deal with it? But when something is wrong, but nobody knows what it is, it's a place where many people find themselves getting so lost.
Sure.
Is it normal to have a regular cycle and still be infertile? And then she follows it up with, is a low ovarian reserve related in any way to your cycle?
Yes and no. So it depends on how low we are.
Yeah.
The regularity of a cycle is directly related to the regularity of ovulation.
Okay.
So if you're regularly ovulating, then you will equally, most cases, be regularly menstruating.
Okay.
So if your ovarian reserve is low, and what that means is that you'll have a lady who is 25 having the ovarian reserve, and by that we mean the stock of your eggs, because ladies are born with all their eggs. We never develop any new ones along the way.
Okay.
And from the time you get the amount of eggs that you have during in your mother's uterus, then are reduced by half by the time you are born, and then reduced by another extra half by the time, that figure by another extra half by the time you're getting to become an adolescent.
Okay.
And then from the time you start ovulating, then there is already ovulation. So there's a constant reduction from your stock. Now, some ladies, for various reasons, will have, for example, a 25-year-old having the egg reserve or the quantity of eggs similar to somebody who's 35.
Okay.
Now, that then becomes then the low ovarian reserve.
Yes.
So the periods can be regular or irregular depending on how low they are.
Right.
If they go down to, for example, 45, your 25 or 45-year-old stock of egg quantity, then that would give you, similar to a 45-year-old, sometimes a bit of irregular periods.
Okay.
So it depends on the quantities. Yeah.
I mean, I think, and I'm sure a lot of women have thought like me. I used to think that, and you've just busted that myth, that there's nothing I can do to create more eggs in my body. What I came with, that's it.
Absolutely, yes.
And there's nothing that science can do to add eggs in my body.
No. So no, not unless you're talking egg donation. Yes.
Right. Egg donation. Okay. So this is also about egg reservoir depletion. It's not really a question, but this lady says, can the doctors be a little kinder to the trying to conceive team? Because I once experienced some not so kind words of a doctor telling me about my egg reservoir that has depleted. And I think it's a lot of women actually raise this concern that, okay, fine, I get it, something is wrong with my body, but can you do it in a kinder way?
True.
Yeah.
And we've had lots of patients come in with a similar issue, and we try, I think, as science is evolving in the workplace and professions, so we are finding that the relationships, of course, being very important, how you portray. So we no longer have a top-down sort of, I'm telling this what's going on.
Yes.
We're trying then to almost be at par, because in the digital age, then everybody has information.
Yes.
And therefore we're speaking at, you're not speaking down at somebody. Yes. So yes, indeed. Yeah. And I can attest, I think most of the professionals in our field and are trying to do that.
Yeah.
But we may have a bit of space, of course, to improve.
Of course, absolutely. 6 years now. Why am I not getting pregnant? My husband and I have done tests and we're told we're okay, and we're both in our 38th year. I guess that's another case of unexplained infertility. Is that what it sounds like?
Yes. So what happens is there's a thing as all tests. So of course it depends on what are all the tests, because one, we try to individualize most of these tests, meaning that you look at the couple and look at their lifestyle and look at their the sexual history and sort of try and figure out if there's a gap there that can be able to try and fill. If that doesn't work, then you can be able to employ all these different kind of tests. Some may be available, some may not be available. So the term all tests now may be variable. And that's why what science does, that we try and reach deeper and see if you can't find something from the tests that we talked about, which are the initial ones, do you go down to the genetic level? Because you could you're finding more and more DNA fragmentation, which means that the DNA, for example, in the sperm is damaged, but it looks very good under the microscope. It's swimming well, you have very good shapes, but then the DNA is damaged. Therefore, it will, even with a very healthy lady, couple or lady partner, be able to not form a good quality embryo. So there's certain things that, that could be accessibility, that is it accessible, or do we need to just dig slightly further and be able to find what the actual issue is?
The issue is. How do you decide, if I come to you as a patient and I have issues of infertility, how do you decide, okay, Kambua, what you need is IVF, or rather let's try IVF, or let's try I don't know, an egg donor or whatever? How do you decide what path is right for me?
So again, since it's very individualized, so you're coming in and then meeting you at your point and saying, now this is what I've done and this is what I'm able to do, and this is what, for example, you can find somebody whose best chance would be through IVF.
Yes.
But I do not have the funds. You know that the costs keep increasing because the cost of the drugs especially is the biggest component in that cost. And that may not be something that we have direct control over currently. So the costs keep going up, and you can tell somebody, no, you may need this, but I don't have the money for this. Can I go on a few extra cycles of letrozole or Clomid or whatever it may be? And so it's you could have what the ideal is, but since as you said, you're talking across the table, and I hear where you're coming from, and this is where we are. So let's find sort of a middle ground and just try this, and pray and hope it goes well. And if it doesn't, then we can, for example, now try and explore other options. So it's always a balancing act, just as you talked about, even work life. It's the same even with the couples, because you have to also see where they're coming from.
Yes. So speaking of couples, because oftentimes it's always assumed that the woman has a problem. and we always think it ourselves that there must be something wrong with me. Could you tell us what is I don't even know if it's to ask for statistics, but do men contribute to issues of infertility, and how much do they contribute?
Yes, they do. Again, it varies, but
Yeah.
when we go to the generalization, when we
Yes.
look at now the sort of worldwide statistics, then we talk about 30% of infertile couples, then the infertility is contributed to by the man,
Okay.
purely by the man, 30% purely by the lady,
Yeah.
30% as a combined factor, which means that you have an aspect of infertility,
Yes.
which coupled with my aspect of infertility as a man,
Yeah.
then would have us be struggling to conceive.
Yeah.
However, your kind of issue with a different partner may be overcome, and therefore you wouldn't have an issue. So that's the combined aspect.
Yes.
But then 10% is what you talk about, the unknown or unexplained infertility.
Yeah.
So 30% is from the male. It's a male factor infertility.
Yes.
But as you said, we are very unevenly yoked.
Right.
And that whenever we come in, even in our clinics, in our fertility clinics, of course, then it's the ladies, and the men will come in after the lady has done the same test 2 or 3 times,
right?
And sort of, everything is checking out. Then now somebody may agree or may not agree to then come in. So, but again, that said, we are sort of seeing a different culture with people being more upfront in coming and for the tests.
And there's there are treatment options for the men as well, just as there are for the women.
Yes, they are. So as long as you identify, because the biggest thing becomes identifying what the exact issue is.
Okay.
So if you're addressing a problem directly, then you're able to find a solution. And of course, the output in regards to that, this couple being able to achieve their desire for fertility is a much sooner.
Yes. Can a couple, is there a way to know before, for instance, let's say before we get married, is there a way to know if we have pre-existing things that could complicate the journey ahead? And what would some of those things be like? What would you tell people planning to get together? What are some of the things they can do to prepare?
Very good. So, because we come from society, and of course society, then you have your inherited conditions, and you have your trends that run in the family. So you find somebody coming and saying, we have a history of polycystic ovarian syndrome.
Okay.
But then that does not directly mean that you could have it. So these are some of the things that of course we come in. So when you're coming to your question that you're having a couple who are coming, I'm visualizing a premarital sort of like a checkup, and get lots of those. So in regards to fertility, the main things to look at is now the family history. So infertility, do you have congenital anomalies? Do you have conditions that could complicate pregnancy, including diabetes and hypertension and other factors? In those initial meetings, unless it's volunteered, then you'll not be going, of course, now checking out genitalia and etc. But then, depending on the depth of the testing, then you can be able to now, for example, pick up something on ultrasound, or you have a fibroid here that is in a place where it's not conducive to carry a pregnancy and may need to be checked on before you do that. But only until, and that's why even in labeling infertility, then there's a time period for it. For under 35-year-old couple, 1 year. For above a 35-year-old, 6 months. So you won't come out and before they've even tried, then you'd want again, because you've had on the flip side people who look like they have, you can find the uterus looks this way. The gentleman has had, testicular injury from previous sports history, etc. But then no problem at all conceiving. So you would not judge right away. Of course, we always give the element of time and the benefit of doubt and hope and pray for the best. But then at the point that they come and volunteering, we've tried for this long, it's now becoming an issue, then we pick it up from there.
Okay, fantastic. Are there family planning methods that interfere with our fertility? So
ideally, by the mere definition of family planning or contraceptives, it is interfering with fertility, because the hormonal contraceptives are stopping you from ovulating. So they're halting the ovulation process. And number 2, they're making, for a lady who are the major users of it, they're making the lining of the uterus, which would harbor or carry the pregnancy, become thin. So these effects are up to the time that they need to be used. For example, let's say if a method expires, or you get it out within a period of about a month to 2-3 months, the effect should be out of your system. Now the question would be, now beyond that, then does it have long-term effects, which in most cases they do not have.
Okay.
For men, of course, then most of them are the barrier methods.
Yes.
And so those ones, they're not being used, then they're not intrusive.
Yeah.
There's been, on the male contraceptive angle, there's been exploration towards male contraceptives.
Yes.
But we always say that for ladies, you ovulate within a period of 12 hours to 48 hours in a month. So that's the only period you're fertile in a month.
Yeah.
And if you miss that period, then you've missed it.
Yes.
But for us, then you're fertile throughout.
Yes.
And therefore, if you come in to give medication to suppress, for example, the testosterone, the side effects are very dark, because you cannot now suppress production of sperm, which is a continuous process, as opposed to the egg, which is a one time in a month. So that's why, and I'm sure that question is coming, then it's more skewed towards the ladies in terms of the burden of contraceptives. Yeah.
Right. There's a question I was trying to find, but I remember what the lady had said. She was talking about why she's been timing her, when she gets together with her husband is usually right before her ovulation. But month after month, she's still not getting pregnant, because she's saying, I time it right so that, how long does sperm live in your body?
3 to 5 days.
3 to 5 days. So her timing is right before ovulation, and she imagines at that point there should be fertilization happening, but it's not been happening. What could be the reason?
So various things. So one could be that the perceived fertile window is actually a different window.
Oh.
But then in comes your ovulation testing kits that now get to give you a more specific timeline in regards to when you're actually ovulating.
Yes.
Then other factors that now post-ovulation would be, do you have hostile cervical mucus, which can then repel sperm?
Yeah.
Do you have blocked tubes? Is your uterus okay? So then there is now further, many different other issues that can come about.
Okay. Is it possible, Dr. Thuo, to plan for, like, say, I want to have twins or I want to have triplets? Is it possible to plan?
It is possible to pray, and so of course then they again, sitting in my practice, of course, it's faith meets science. And you see all the time people coming in and doc, next time you see me, I'll be here with twins, and they manifest and they come in.
Okay.
So there is that aspect that you're sitting and there's faith and it happens. Now, on the science front of it, then on the science side of it, we can increase the chances of, for example, increasing ovulation. So you'll have 2 or 3 mature eggs that are released, which then increases the chances that at least more than one will be fertilized, which increases the chances that at least more than one will implant and result in a twin or multiple pregnancy.
Yeah.
Yes. However, it is not a guarantee.
It's not a guarantee.
Yes, not a guarantee.
Yeah. I mean, I think at some point I thought, entertaining the idea of having twins, okay, sounds good. But then I was like, what if they're like 5?
Yeah, so there's a...
I'm like, I'm not sure. And of course, that has been the blessing for some people, is having 5 or 6. There's a question here. What's the delivery method for a person with a history of an ectopic pregnancy? Is it CS or vaginal?
Okay. Now, so history of ectopic pregnancy means that you have had a pregnancy occupying the fallopian tube, as opposed to moving down into the uterus, where it then would potentially then grow to a baby and go on towards delivery.
Yes.
Now, outside of, let's say, a blocked tube, in the subsequent pregnancy, because now I'm imagining now that after the ectopic, then we've been successful in conception, and then you have a new pregnancy, and the pregnancy is okay. So the decision about mode of delivery comes not because of, so the existence of an ectopic is not a consideration.
Okay.
It now becomes other factors, which we say, how is the baby, or what's called passage, and how is the passenger. So the baby is a passenger.
Yes.
How is the passage, including the cervix and the pelvic bone, and then how the contraction. So it's that's a consideration, as opposed to if you've had an ectopic pregnancy prior or not.
Yes. Yeah. If I have had a CS, how much time should I take before I try to conceive another baby?
Variable. So we, where we sit, then we have couples who come and they have different, so their idea of what we refer to as the desired family size is very different for different people. So you have people who, for them, a period of 1 year without conception, let's say the other baby is 1 year, then we've stayed too long. We should have conceived another one before this baby turns 1 year. Whereas others then will come in and want to, a longer period, 5 years, so that we can give adequate time and because of work factors, etc. WHO would put it as 2.5 to 3 years because that allows for the baby to have been given, for example, adequate care and adequate attention, and they move from being independent, from being dependent, fully dependent, to semi-independent, and then you can be able to bring another one in. But of course, remember then a couple's desires and plans are very different. So we just honor those ones and then let you know. But for a C-section, pre-C-section would not advise before 6 months to then be trying for a pregnancy. But after you've weaned the baby, if you're in, your desire is to have a pregnancy earlier, then after 6 months, you can try.
Because then you're sure that you've sort of healed.
You've sort of healed, the uterus has healed, the hormones of pregnancy have dissipated, and if you are in the space of mind and your society and your, what calls your family, so your support group allows, then you can be able to go and get more. Absolutely.
I am at that place where I'm at the advanced maternal age. Is there an age where you advise women not to try have children, or is it open for as long as I'm ovulating and having my period?
No, we don't. So again, very, very varied. So people are very different, and there's you don't give a cutoff per se. What we do is give you what the potential chances are, and of course we are able to pretty accurately predict that, by if you're trying to conceive at this age, then your chances are at this level. Therefore, it would take you probably longer before you get to conceive. So we can give you what the chances look like. Remember, nature is very, very different. So coming in here, so I've had a 49-year-old lady. She's pregnant, and I was just thinking just before I literally came over. It varies. So people will have babies differently. Those are at different times. You'll have a 21-year-old really struggling. So we don't give. I said just give what the chances are likely to be, but you
don't say that,
no, we just tell you, for example, then you've tried it this time, let's try something which can increase your let's do something that can increase your chances to conceive faster.
For women who are pregnant and end up having babies born with special needs, I know one of the questions that keep coming up is, couldn't this have been picked up when I was pregnant? Is it possible to pick up on some of those, say like Down syndrome? I spoke to a mom who's had 2 children with SMA. Of course, now they know it's a genetic whatever. But the question is always, couldn't it have been picked up when I was pregnant? Is it possible to?
Yes, it is. And I was talking earlier about the depth of the test that you can be able to go into. So the obvious, for example, physical anomalies you can be able to pick up on ultrasound. And the early ultrasounds going into, let's say, about 12 weeks are very instrumental in trying to pick up some of those issues. And we have fetal maternal specialists, for example, because it's not my specialty, then we're able to send in and say, I'm seeing there are certain features here, and I'm able to, for example, to escalate to them. Now, an ultrasound can also look very normal all the way to the end. And you find the issue is not a structural issue. For example, it's a brain development issue, or so there can be various factors. On the flip side again, so we have parents who come in and you have obvious issues on ultrasound, for example, that then may warrant even a termination of pregnancy. Now, so you're giving the chances that, because we only double by because of history and research, then you see, of course, in a situation like this, this has been the outcome in other similar situations. But then find couples say, what, I'll be able to go on with this pregnancy, even including with very gross abnormalities and the rest. So Yes, let me say it varies.
Yeah. And I think you're also mentioning that it's so important to see to start going for your prenatal once you find out that you're pregnant.
Yes, as soon as you do.
Because a lot of women, you know, I joke about this a lot even on this podcast, because I am those women who, as soon as I see that pink line, you better trust I'm in my doctor's office the next morning. That's me, you know, I'm like over the top.
Yeah.
But then I would get so surprised by women who are like, me at a Sijai clinic, and they're like at 8 months.
Yes.
And I'm like, how did you do it? You know, how have you done this? And we don't see that there's so many risks that come with being unaware of what's happening, right? So just stay on top of your body by doing what you need to do, right? Dr. Thua, we are winding up now. There's been a question on miscarriages, just having recurrent miscarriages. Is there any kind of treatment to help women sustain pregnancies? A woman who's had, some have had 8 recurrent miscarriages. Is there anything that can help women sustain and stop that condition? And what could be causing recurrent miscarriages?
So again, identifying what the issue is then really helps us to give a solution and a viable solution to the issue that's at hand.
Yeah.
So recurrent pregnancy losses you can find in the first trimester tend to mostly be genetic.
Yes.
So in genetics, then you talk about, is it the quality of the egg, is it the quality of the sperm? Or do we have an issue with the lining of the uterus where the pregnancy is going in, that it's not adequate to carry a pregnancy? So identifying what the issue is, then we'll be able to sort of allow you, for example, if it's the lining that's the issue, there's medication to sort of help it support more.
Yeah.
There is lifestyle changes. There is, reducing what you refer to as pelvic rest. There is medications to increase blood supply to the endometrium.
Yeah.
There is medications to remove barriers to implantation. We go in and put in a scope or a camera into the uterus and find out if there's issues that's like infections and inflammation and polyps that can be able to cause that. If, for example, it's a genetic issue with the quality of the eggs, then you're not able to increase the number of the eggs, but you can increase the quality of the eggs through multivitamins and diet and exercise and stress management as well.
Yes.
Remember, WHO again defines health as a complete physical, emotional, psychological well-being. So even when you're sitting across, then you could find like there's just a stressor. There is let's say too much pressure on the lady, that now the psychological aspect of we need a baby now, then is affecting her physiological functioning, and she's not able to carry a pregnancy. So there are those factors that now, again, it's individualized, that when you're sitting across, you try and pick up onto those ones. And how does this make you feel? And how does this? And what have you tried before? And being individualized, you try and tweak things in a way that can actually help them.
Last question,
No worries.
What kind of intervention do women who are told they have a low-lying placenta, what kind of intervention is done for them?
Now, low-lying placenta may be symptomatic, may not be symptomatic.
Okay.
So low-lying placenta means that the placenta is in a position where it's covering the cervix, which is the mouth of the uterus into the birth canal.
Okay.
So if it is there, in most cases, it can shift out of the way from the beginning of the pregnancy, and gradually by the time the baby is term, then there is enough room for the baby to actually come through the birth canal. In some cases, then it's low-lying and causing heavy recurrent or persistent bleeding in clots that threatens the pregnancy in and of itself. In other cases, then it's for example, if you go in delivery, you have to go do an earlier delivery, because the placenta may threaten, for example, to separate. So it's again very individualized. But finding out what the issue is then is the solution. So sometimes just bed rest and medication. Sometimes it's earlier delivery that would work. That can be the bridge between, of course, saving the pregnancy versus waiting too long and you end up losing the pregnancy. So it's a balancing act.
It is a balancing act.
Yes.
Finally, is surrogacy legal in our country?
Very good question. So we have had this reproductive health bill. that's, I think, a starting parliament for years, probably decades now, that's not been pronounced yet, which would give adequate guidelines into how do you proceed with egg donors and sperm donors and embryos and how long can you freeze them and what are the conditions that this and this should happen.
Yes.
Now, in the absence of that, then we tend to rely a lot on international fertility law. So where you'll try and then keep within that, because remember we are world citizens, so people are again aware about what's happening, and you out there, and if you have a desire for pregnancy and there's a solution, for example, would be that you're not able to carry your own pregnancy, then the surrogacy option then is there. So we do go ahead and do the surrogacy, actually quite a lot of surrogacy programs that are going on. But then you try and have the surrogate protected and also the intended parents, as we call them, protected, so that you're giving them, so on either side, because the fears that go would be of, when the baby is born and is born by the surrogates, then what does their birth notification read? And am I adopting then my own baby back to myself? What if the surrogate refuses? So there are a couple of those factors that go in. What if there's foul play and the surrogate decides, I'll keep this baby and it will be blackmail. So there's a lot of those factors. So trying to come in again, individualized, you sit down, you try and do, so we sit across the table with the surrogate and the intended parents, in some cases separate, because sometimes then we keep that anonymity, so but then try and work in a way that you try and harmonize so that their desires are met. Again, so with the absence of that, then it's a bit tricky, but with international law, then we try and put in the necessary.
Do people come with, I'm sure there's cases like you've said which are anonymous, but are there people who come in and will tell you, this is my sister, she'll be my surrogate?
Yes. So the different types of surrogacy. So there's genetic surrogates. So that means that this is my sister, and she has graciously allowed or agreed to go ahead with this process. And you sit across and just explain what that entails, what the risk factors are, what she'll need to go through. There is not so many of these ones, but there's what you refer to as voluntary surrogates. That means that, I've had my babies, or I do not want to have babies of my own, but I don't mind carrying a baby for somebody else, and I may not need compensation for the same. So that's voluntary. Then comes the commercial surrogates. So commercial surrogates are screened. Then, so screening is done, and there's background checks, and there's, there's the necessary, of course, there's the screening for infections, etc. Then they get to come, for example, to the table as potential candidates. Then now further screening is done, and you have, of course, to then coordinate with the intended parents to confirm that it's a match. And so there are various factors that people look at. So I want somebody who's this old or this young. So there's again individualized,
depending on what you're looking for. Wow, Dr. Thuo, thank you. As you can tell, I'll just keep pulling questions, so let me stop.
No worries.
But thank you so much for just sitting with us and sharing that information with us. I know people will be like, okay, if we want to contact Dr. Thuo, where can we find you? Where is your practice? Please look into the camera and share that.
Thank you. So we are located at La Femme Healthcare. So La Femme is just it's a French meaning for the woman. So because then we deal with the woman as a pillar of the family. And of course, we've talked about the lady quite a lot in this conversation. Then, so La Femme Healthcare. So we are at the Greenhouse Mall, and there's La Femme Healthcare, and then there's La Femme IVF, which of course then is the fertility wing of La Femme. Yes. Thank you so much. You're most welcome.
Yes, and thank you all so much. I will put that information on La Femme right below this video. If you'd like to visit the clinic, get to talk to Dr. Thuo. It's so important to know what's going on with your body so that we're not guessing and asking each other questions that we cannot answer. Thank you so much for being here today, and I look forward to catching up with you again next week. Take care and God bless you.
The usual things you do before you get to bed. She's so heavy. She's 1 week. She had 1 week to
deliver
elective CS because all her kids were CS. And we have gifts, I had birthday gifts for her, but they were not wrapped. So I look at her, I'm like, let me pray for you. on your birthday. So I prayed for her while you're in bed, prayed for her. And she was happy, she smiled.
Yeah.
And as she's settling in bed, she like tried to turn. She was facing me, so she tried to turn and face the other side.
Yeah.
And as she was trying to face the other side, you know, you've got to move.
Yeah, it's really hard.
It's really hard. She says, ouch! And she's holding the lower part of her belly or abdomen.
Yeah.